What to expect for your embryo transfer, different types of protocols, and what to know. Hi, friends. I'm Dr. Natalie Crawford. I'm a board certified OBGYN and REI. I'm a fertility doctor, and I talk to patients all the time about their embryo transfer, which is the final process of IVF. And today I'm breaking down what you should know about the frozen embryo transfer. Before we dive in, a huge thanks to be here. I always appreciate if you subscribe, like, share, comment on the videos. We get a lot of our content from the questions that you are asking. And as always, you can learn more from the Fertility Formula, my new book, which is out, which is going to help prepare you no matter if you're trying to get pregnant now or deep in the midst of infertility or just want to be pregnant someday, but not yet. When it comes to the terminology, let's break this down. IVF or in vitro fertilization is the act of going through the process of growing 1 month's group of eggs, getting them out of your body, fertilizing them in the lab, that's the in vitro, and growing out an embryo. Embryos can then be frozen, transferred, or they can be biopsied and frozen. When we do a frozen embryo transfer or an FET, this is going to be actually taking those frozen embryos and then thawing them and putting them inside your body. When we do that, there are a few different ways that we have to prepare the body for the embryo transfer. And the bulk of what I want to go over today is the different types of protocols that exist just so that you can know the difference. And I must say, there's not a one size fits all approach here. Your clinic probably has some personal preferences, but there should always be flexibility to what is best for your scenario and an honest discussion about the risk benefits of different protocols for your unique situation. And sometimes we have to get creative because we see something is not working. No matter what, when we have a genetically normal embryo, which is the most testing we can do right now, our success rate is 65% per embryo. So that means that even if everything's perfect, we do a cycle, you may not be pregnant. And that can be very disheartening. That doesn't always mean we have to change something. Very often for a second embryo transfer, if I liked how things looked the first time, I'm doing something very similar, if not the same. That is because the cumulative rate of success after 2 transfers is about 85%, which is much higher. Now, if we've had 2 transfers and we don't have success, then we have to start thinking about, are there different protocols that could make sense for us, further testing that can be done, and we just want to expand our viewpoint. Officially, recurrent implantation failure is defined as 3 normal embryos, so genetically tested embryos, that have not worked. So once we get to that stage, we absolutely need more testing and more thought to the protocol. But embryos are not always a limitless resource. So sometimes we have to start thinking about those things earlier, and we have to pull into the picture your own history. Did you have miscarriages on your own? Do we think or know you have PMOS? Do we think or know you could have endometriosis? What is your reason for infertility that got you into this place? And all of that should influence what protocol we choose, in addition to what does your lining look like in your IVF cycle. So let's break down some of the protocols. Once I have an embryo, I'm now in the unique position where I can get the lining exactly where I want it. Sometimes in natural cycles, there is miscommunication or some mismatch between when this embryo is perfectly ready and arriving in the uterus and when your uterine lining is ready. And so we are allowed to overcome this in IVF because the embryos have gotten to the right stage. And now I can take the time to get the uterine lining to the right stage and pair them up. The way I want you to think about embryo transfer protocols and how I describe it to patients is, imagine there's 5 different types. So we're going to go from least to most aggressive, but that doesn't mean it's least to most successful or even better. It's just different ways to think about it. So number 1 is going to be a pure natural cycle. This is going to mean in your natural cycle, you have an implantation window that exists. So if you are ovulating, if I know when that ovulation occurs, I know when that implantation window exists. So a true natural cycle has no medications added onto it. You are tracking ovulation and putting an embryo inside. You're making your own progesterone from your corpus luteum. You're growing your own lining from your own estrogen. Remember what's happening naturally. Eggs are coming out of the vault. Each egg is in a follicle. Brain sends out follicle stimulating hormone, or FSH. FSH is going to get the egg to grow, and as the egg grows, it makes estrogen. That estrogen is going to get the lining to grow, and that lining should then become what we call trilaminar, very organized when you see estrogen only, and we typically want it to get at least to 7 millimeters thickness by the time the egg is mature. In a natural cycle, this would then cause LH surge. LH would have the follicle rupture, egg be released, follicle reform, and then would start making progesterone. Remember that progesterone opens and closes the implantation window. So progesterone is then going to determine when you are going to have that success. So typically it is after about 5 to 7 days of progesterone exposure is considered to be the implantation window. Corpus luteum makes progesterone in pulses. So in a pure natural cycle, we are putting the embryo in that 5 to 7 day window. after you are naturally ovulating. Nothing else is being done. This can be great because you're not taking or paying for additional medications. Timing, you have to really be careful to detect ovulation. We don't tend to do this as much because we like to control things more. And also, if you didn't have success conceiving in your natural cycles, it begs the question on why we think this one would be different. So I do not love this for recurrent implantation failure, unexplained infertility, or prolonged primary infertility. Second is going to be what we call a modified natural cycle. The same premise, you're going to use your own endogenous estrogen or estrogen from your ovaries to grow the lining and prepare it. You'll ovulate and make endogenous progesterone, and that will start your implantation window. But in a modified natural cycle, we're taking a little more control, which REIs love to do. This means we are getting you to ovulate. This is typically either with an oral medication called letrozole. Letrozole works to get the brain to send out stronger signal of FSH, or we're giving you gonadotropins directly, FSH shots like Follistim Gonal F or Menopur combined FSH LH. So we're giving you something to get an egg to grow. That egg is going to then make estrogen. Monitoring so that we can usually do a trigger shot to force ovulation to happen so we can really control timing. And then we're going to usually supplement with some progesterone in this cycle. So you're making progesterone from the corpus luteum and pulses from the LH pulses from the brain, but now we're going to add a little bit bonus to raise that kind of bottom threshold of progesterone. Typically, vaginal progesterone is given because we just need to supplement. We're just going to augment. You're making some naturally. Now, the benefit here for a natural cycle is it's really well tolerated. It's faster. Looks like where it's associated with improved birth outcomes for some patients. We might be able to have a lower risk of preeclampsia. There's still a lot to be determined on medical research here. But similarly, if your natural cycle has never worked to get you pregnant, is this the best option? On the other hand, many women have a lining that grows better to their own estrogen than to synthetic estrogen. So a modified natural cycle may be good if we have history of thin lining or Asherman's. It may be good if we've had a child before and now we're in infertility for a different reason, but it's something to consider. And sometimes when I'm not having success, I come here and we see a really different outcome. Nuance is that it's less predictable. You don't tend to get a calendar. We're going off your body. So you have to have more flexibility in what is going on, but ultimately usually less shots than these other transfer options. So I consider that number 2 on the aggressiveness. Number 3 is going to be a controlled or medicated cycle. For a controlled or medicated cycle, we're going to get the lining of the uterus to grow with estrogen. So you take estrogen. This can be synthetic estrogen, estradiol, pills, patches, injections, vaginal pills, all of the above can work. So you often are leading into a controlled cycle, either just starting it after a period. Maybe you're using birth control pills first to suppress, but in option number 3, you're just growing the lining with estrogen, doing ultrasound for monitoring, and then there's no ovulating because the ovaries aren't doing anything, and you're going to start progesterone. Because you're not making any progesterone in this cycle type, you have to use intramuscular progesterone. That is a bigger needle. It is not fun. It's called PIO or progesterone in oil. It's a little thicker. Now, a controlled medicated cycle in this option is probably the most common protocol done, at least in the US. It is not my favorite one because we're not getting some of the benefits of the natural cycle. We are getting some calendar control, but for the most part, we're not getting some of the benefit of the immune suppression we can get from some of the, we'll call them more advanced protocols. The nice thing about this one is it's not dependent on your body. If you don't ovulate on your own, then we don't have to rely on that. Or if you're an ovarian failure, you're in menopause and we're going through a cycle, these options and on can be advantageous. Option number 4 is going to be one of my preferred options if we're trying to do a medicated cycle. And this is going to be very much the same, but we're going to add in Lupron. Lupron's a GnRH agonist, meaning what it does is it binds in the brain and it causes the pituitary gland to send out all of the FSH or LH that it has, but then it prevents more from being made. So it kind of dumps everything and then it's low. This lowness causes a suppressive effect. And we can prevent any flares from this first release if we start Lupron either in the luteal phase when FSH and LH are depleted or overlapping it with birth control pills. Lupron can suppress adenomyosis and endometriosis. So we get a suppression of some of these chronic inflammatory diseases, and this can be advantageous for success, especially in known circumstances from those conditions. There's different ways you can use Lupron. You can use it subcutaneously for about 30 days. You can use it intramuscular shot that can last for 30 days. You can use it for 1 month, 2 months, 3 months. There's some nuance here for what you should do, but most of us prefer some pre-suppression with Lupron if you have known endo or adeno. And then for me, if you have unexplained, or I do a lot of presumed endometriosis because you have symptoms even without a formal diagnosis, I am leaning on Lupron in these circumstances. And then option number 5 is going to be the recurrent implantation failure protocol. And this is going to be 2 months of Lupron suppression, typically with letrozole. So daily letrozole and 2 months of Lupron, so that we really downregulate your low estrogen. It's not fun. It takes time. But then we can get that lining to grow with estradiol and then still use the progesterone. So it's like an even more advanced immune control. Now, there's a lot of nuance here. And sometimes even we suppress with Lupron and then we come in and we try to get a modified natural. That can be a little bit hard because I've just suppressed the ovaries and now I want to stimulate them, but it can be done. And sometimes that's what a patient needs. So, what I hope you're hearing is that it's not a one size fits all. A good question to ask is, what was my lining in my IVF cycle? Because that's one of your highest natural estrogens you're ever going to have. And if your lining was thin then, it is insight to us that you are going to have a thin lining. And this is something we need to think about. Some other top tips and thoughts really quickly, and we're going to go over embryo transfer tips in another video. But number 1, I require patients to have a saline sonogram, an HSG, or a hysteroscopy, some type of uterine cavity evaluation within 6 months of the embryo transfer. There's nothing worse than failed transfers and nobody's ever looked inside the uterus and you have scar tissue, polyps, or something that's preventing success. Number 2, there are add-ons that we sometimes do that haven't been shown to be harmful, plus minus on evidence that can be helpful. But some of these do include adding baby aspirin on board, sometimes a short course of steroids or antibiotics, and those are some more standard ones. What about the progesterone situation? I want to address that if you're using a cycle where you are not making any progesterone and we are replacing it completely, studies are very clear that you need to have some progesterone in oil. That is not debated anymore. You can either take it every day or you can use it every other day and you can have some vaginal progesterone added on board. If you are ovulating in any type of modified or natural cycle and you are making some progesterone, you can then use just vaginal progesterone only because you are just supplementing. So this difference is quite profound and we really need to make sure that we are supporting with enough progesterone. Progesterone opens and closes the implantation window and is essential for success of the pregnancy prior to the placenta fully functioning at about 10 weeks. And we know that if we lose progesterone before then, you will lose the pregnancy. So nuance, but hopefully this is helping you think about the different protocol types that exist to at least understand if you're going through an embryo transfer. I always think it's important to ask your clinic, which protocol are you wanting to do and why? And there's probably a good reason, but this is going to help you understand what exists, what we know, what we don't know, what limitations there are, and understanding that it's not as easy as one protocol for everybody, but we want to be making the best evidence-based decisions that we can. And we'll go over embryo transfer day tips coming up soon. Thank you guys so much for listening. Ask your questions below. As always, you can get more information on the As a Woman podcast or on Instagram at Natalie Crawford MD and check out the fertility formula.